Salam alaikum. Now, it's a second part of the gastroenterology video regarding 10 page at a row. Like to discuss about the food protein induced allergic proctocolitis. Food protein or milk protein induced allergic proctocolitis. Risk factor is family history of the allergies, eczema, and asthma. Allergies, eczema and asthma. There is well-appearing infant with painless bloody stool. Well-appearing infant with painless bloody stool which may be loose during the first few months of life with or without spit off. Treatment is elimination of milk and soy from maternal diet. Elimination of milk and soy from the maternal diet in breastfeed infant. Hydrolyzed formula containing pre-digested protein. Hydrolyzed formula containing pre-digested protein in formula feed in infant. Prognosis is spontaneous resolution by 1 year. Parents should be reassured that the prognosis. Parents should be reassured that the prognosis is excellent. Almost all affected infants can tolerate dairy and soy products by age 9 months. It is a non-Ig mediated reaction in which a protein in the infant's diet, breast milk or formula, causes eosinophilic inflammation of the distal colon and the rectum. Cow's milk, casein, whey, and soy proteins are almost frequent triggers. These are all frequent triggers. Diagnosis is clinical and confirmed when bleeding ceases after maternal dairy elimination. Visible bleeding should resolve within 3 days, but occult bleeding may persist. Up to 2 weeks. Most breastfed infant responds to maternal elimination of the dairy alone. Additional elimination soy usually are recommended only for persistent symptoms to avoid severely restricted maternal diet. For formula feed infants, switching to an extensively hydrolyzed formula which contains pre-digested cow's milk protein and is free of pottage cross-reacting soy protein and is ideal. Persistent bleeding and amino acid based elemental formula may be required. Symptoms typically resolves within a days to weeks. IgA mediated anaphylaxis can occur in any age, is immediate less than 1 hour. It may be urticaria, vomiting, wheezing, angioedema, and hypotension. Non-Ig mediated food protein induced allergic proctocolitis less than 6 months. It's an insidious in onset, painless, bloody stool, and well appearing infant. And non-Ig mediated for protein induced enterocolitis syndrome less than 12 months within hours, profuse vomiting, diarrhea, dehydration, and lethargy, and ill appearing. It's a very important topic that management of food protein induced allergic proctocolitis. Infant with presumed food protein induced allergic proctocolitis. If he is breastfeeding, eliminate the trigger from maternal diet. Eliminate the trigger. If breastfeeding infant, eliminate the trigger of the maternal diet like dairy, soy. If the baby is formula feeding baby, switch to hypoallergenic or hydrolyzed formula. If symptoms if there is a resolution of the symptom, then food protein induced allergic proctocolitis is confirmed, reintroduced offending protein around age 1. If no, consider evaluation for alternate diagnosis and flexible sigmoidoscopies should be done. Blood strip stool in a well-appearing infant aged less than 6 months are usually due to anal fissure or food protein-induced allergic proctocolitis. So less than 6 months baby with a history of blood streaked stool. Think about two differentials. One is food protein induced allergic proctocolitis, and the second one is anal fissure. Okay, crying in young infant. If you find a crying infant, first of all, you have to know what is normal. If intermittent consolable cry less than 3 hours per day, that means intermittent comes and goes. Consolable, he can be consolable, and less than 3 hours a day, it is normal. If more than 3 hours a day, if more than 3 hours a day, usually in the evening and more than 3 days a week, think about colic. More than 3 hours a day and more than 3 days a week, think about colic. Healthy infant age less than 3 months. So in colic, rule of 3, that more than 3 hours a day, more than 3 days a week, more than 3 days a week, and the last thing, usually age less than 3 months. In GERD, there may be frequent spit up, back arching after feeding, back arching after feeding. If it is infection, it may be ear infection, it may be brain infection, it may be urinary tract infection, it may be pain in the bones or joints. So, first infection, acute otitis media, bulging tympanic membrane, erythema, alone is not diagnostic with or without fever, meningitis, fever, lethargy, bulging frontally. Fever, lethargy, bulging frontally, and septic arthritis, fever, limited extremity movement, and UTI, fever, vomiting, poor feeding, fever, vomiting, and poor feeding. Then intussusception. Intussusception means organ, telescoping of one part of the colon into another. In here, there is episodic irritability with legs drawn to the abdomen. This is very high health thing. If the baby legs drawn to the abdomen, irritable baby legs drawn to the abdomen, and bilious, vomiting, bloody stool, bilious, emesis, bloody stool. Think about intussusception. In torsion, there may be testicular swelling or abdominal distension. Testicular swelling or abdominal distension. There may be trauma, hair tourniquet, hair accidentally wrapped around the digit, hair tourniquet, corneal abrasion, tearing, photophobia, and fluorescence test, abuse or fracture. Abuse or fracture like bruising, laceration, and asymptomatic movement. Bruising, laceration, and asymptomatic movement. In acute otitis media, there is a bulging tympanic membrane and or middle ear effusion with tympanic membrane inflammation, and there is erythema. Tympanic membrane erythema alone is not diagnostic of this condition. Colic crying usually occurs around the same time of the day, evening, and parents often have difficulty consoling the infant. Only during this time, symptoms peak at age less than age 6 weeks, typically resolves by 3 to 4 months. The cause of colic is unknown but may be related to gut immaturity or suboptimal feeding technique, excessive swallowing, or here a complete history and physical should be performed because colic is a diagnosis of exclusion. Initial management includes providing parents reassurance and support. Soothing techniques should be reviewed and include a pacifier. Soothing techniques should be reviewed, including a pacifier and holding, rocking, and swallowing the baby, minimizing environmental stimuli. Okay, differential diagnosis of these regurgitation and vomiting in GRD. Uh, it may be physiologic, like this word is very important. Happy spitter. Baby is very happy and spitting a lot. Happy spitter and wants to eat and drink. Think about physiological form of a GRD. Reassurance and position therapy. Usually, after feeding, barping should be done. Usually, after feeding, the baby should be kept to remain in sitting position, not in supine position. Mm, these may cause GERD. Pathologic is failure to thrive, significant irritability, and Sandifer syndrome. Failure to thrive, significant irritability, and Sandifer syndrome. Thickened fits, antacid therapy if severe esophageal pH, probe monitoring, and upper GI endoscopy should be done. Milk protein allergy, there may be regurgitation, vomiting, there may be eczema, there may be bloody stool, elimination of the dairy and soy protein from food, from diet. Then the pyloric stenosis, projectile non-bilious vomiting, olive-shaped abdominal mass and dehydration and weight loss. Projectile non-bilious, projectile non-bilious vomiting, olive-shaped abdominal mass, dehydration, weight loss, and abdominal in pyloric stenosis, abdominal ultrasonogram and pyloromyotomy should be done. In gastroesophageal reflux is a common in infants is due to shorter esophagus, incomplete closure of the lower esophageal sphincter, and greater time spent in the supine position. In physiologic GERD, there may be immature lower esophageal sphincter, immature lower esophageal sphincter. Clinical feature is speed up, normal weight gain, no pain or back arching. Management is upright positioning after feed. Upright positioning after feed, burping during feeds and frequent and small volume feeds. Most infants are asymptomatic happy speeder, feels comfortable after burping. Patients should be reassured if examination, growth and development are normal. Treatment consists of education, supportive measures, advice frequent small feeds, hold the infant upright for 20 to 30 minutes of feed, and place the patient prone when awake. Prone while sleeping can increase the risk of sudden infant death syndrome. So think about this also. You are trying to do it for good reason, but if the patient is prone, they may get sudden infant death syndrome. Activities that increase intra-abdominal pressure, fastening the diaper to tight, bringing the knees to the stomach uh, should be avoided, and regurgitation usually improves around age 6 months and resolves in 1 year. The pathologic GERD include failure to thrive, poor weight gain, drop in the growth percentile, and Sandy Fire syndrome. That means intermittent opistotonic posturing. Taken feeds, adding oatmeal, antacid therapy, proton pump are the first line in the management of GERD. These interventions are unnecessary for physiologic reflux, as thickened feet can cause excessive weight gain and PPI, increase the risk of pneumonia and diarrhea. Cow milk protein based formula, which is different from cow's milk, is a standard infant formula. It provides infant with necessary nutrients. Goat milk is deficient in folate and it may result in macrocytic anemia. Very, very high yield information. So approach to the straining infant. How do I approach a straining infant? The baby is doing this type of sound and he is making noises. Then you have to look, is ill appearing or well appearing? If he is ill appearing, or there are some red flags like severe abdominal distension, abnormal rectal tone, sacral findings, delayed passage of the meconium, failure to thrive. If you find these feature, ill appearing infant, these feature, look for serious organic causes like Hirschsprung disease, like cystic fibrosis, and that cases you have to pass the HSC. Hirschsprung disease, spinal dysraphism, hypothyroidism, spinal dysraphism, and cystic fibrosis. Hirschsprung disease, hypothyroidism, spinal dysraphism, and cystic fibrosis. If the infant is well appearing, loose stool without mucus and blood, that is food protein induced, proctocolitis or enterocolitis. If there is normal stool consistency, think about normal infant dysphagia. If hard or pellet-like stool, functional constipation with or without anal fissure, if blood present. So think about ill appearing and well appearing. In ill appearing, think about HSC, hypothyroidism, um, Hirschsprung disease, spinal dysgraphism, and cystic fibrosis. If it is well appearing, uh, then loose stool, and or mucus blood. Then think about food-induced protein enterocolitis. If normal stool consistency, think about normal infant dysphagia. If hard or pellet-like stool, functional constipation, and functional constipation with or without anal fissure if blood present. If infant dysphagia, a common benign functional stooling disorder, pathogenesis of infant dysphagia involves failure to coordinate, increased intra-abdominal pressure with relaxation of the pelvic floor muscle, inadequate abdominal muscle tone to produce an effective Valsalva maneuver. These mechanisms results in characteristic findings of crying, turning red in the face, and straining for greater than 10 minutes, and followed by passage of the soft non-bloody stool. Infants are otherwise well appearing with no abnormality on physical examination, and infants gut nervous system mature. Defecation becomes more coordinated and infants' dysphagia resolves spontaneously, typically at age 9 months. Episodes may be concerning to the parents, and but management includes providing education and reassurance alone. Switching to soy formula can be considered to straining from food protein-induced allergic proctocolitis due to milk. Pediatric constipation, initiation of the solid food and cow's milk, toilet training, and school entry. These three is an important risk factor for pediatric constipation. Clinical feature is painful, hard, but bowel movement, stool withholding, in encopresis, that means fecal incontinence. Encopresis, that means fecal incontinence. Complication is fissure, hemorrhoid, and neurosis. Fissure, hemorrhoid, and neurosis. Anal fissure, hemorrhoid, and neurosis, urinary tract infection. Treatment is with dietary fiber, water, milk, limit cow's milk intake less than 24 hours, laxative, and suppository cinema. If all treatment fails, then anal manometry to rule out Hirschsprung disease. To anal manometry to rule out Hirschsprung. If First of all, look for the risk factor: toilet training, baby, toilet training, school entry, and initiation of solid food and cow's milk. These three can cause constipation. There may be hard stools, stool withholding, and incorporates fecal incontinence. Complication is fissure, hemorrhoid, and neurosis. Treatment is dietary fiber, laxative. Then pediatric constipation. In pediatric constipation, there may be pathologic, there may be functional. Pathologic is delayed meconium passage, functional is solid food introduction. Delayed meconium passage and Down syndrome, delayed meconium passage and Down syndrome associated with Hirschsprung disease, intestinal atresia, stenosis. Functional is toilet trainings, solid food introduction, and school entry. History is poor weight gain and linear growth, blood mixed in stool and bilious vomiting. Poor weight gain, blood mixed in stool, and bilious vomiting or fever. Absence of pathologic feature, painful, infrequent, large caliber and pellet-like stool, and fecal swelling in corporaces. Examination is displaced anus, increased rectal tone or sacral anomalies, hair tuft abnormal, lower extremity neurologic findings, abnormal lower extremity neurologic finding, weakness, and severe abdominal distension. And functional is absence of pathologic feature, mild abdominal distension, and anal fissure, without rectal bleeding. Management is a workup for organic causes, common is celiac disease, hypothyroidism, urgent is Hirschsprung disease, cystic fibrosis, and spinal dysraphism. Mm, for pathologic condition, for functional condition, there may be age-appropriate toileting plan, dietary changes, and laxative. Age-appropriate toileting plan, dietary change, and laxative. Benign features refractory to functional constipation management may also be pathologic. Functional constipation often presents around 6 months because the major risk factor in these age group is a dietary change, that is solid food with a relatively low fiber and decreased fluid content. Growth is normal. Physical examination is often unremarkable. However, mild abdominal distension and left lower quadrant firmness, palpable stool may be present due to stool retention. In addition, large caliber stool can cause anal fissure and bright red blood on the outside of the stool. Initial management is dietary include apple, prune, pear juice, apple, prune, pear juice, non-digestive osmotically active like sorbitol can be given. So first give slow things like apple, prune or pear juice. There may be you can give non-digestible osmotically active carbohydrate like treatment or functional constipation. Polyethylene glycol can be considered. Salam alaikum. Now cyclic vomiting syndrome. In cyclic vomiting syndrome, history is personal or family history of migraines. Personal family history of migraines episodes have identifiable trigger infection or stress. It may be stereotypical, it may be between episodes. Stereotypical for vomiting episodes: acute onset of nausea, abdominal pain, headache, vomiting. It may be self-limited, lasting 1 to 2 days. It is in between episodes, usually asymptomatic, often regular in intervals. And cyclical vomiting syndrome treatment is abortive. Streptons can be given. Antiemetic rehydration should be done. Most children have a gradual resolution of the symptom during adolescence. Cyclical vomiting syndrome is a diagnosis of exclusion, often requiring a lab evaluation imaging during acute episode to eliminate urgent cases of acute vomiting and abdominal pain. Marijuana is a major risk factor in the absence of known medical benefit, and cessation should be recommended. Preventive therapy include amitriptyline age more than 5 and cyproheptadine age less than 5. So amitriptyline more than 5, cyproheptadine less than 5, family history of migraine, and there is family history of migraine, and there is history of recent infection, and then the vomiting occurs and it is self-limited. That is all about cyclical vomiting syndrome. Common association may be meconium ileus. Common association. That means meconium ileus is associated with cystic fibrosis, which causes sinopulmonary disease. Hirschsprung disease is associated with Downs, and it can increase the risk of early onset Alzheimer and hypothyroidism. Bicuspid aortic valve is a common internal. This is the association. You have to remember a diaphragmatic hernia can be isolated animal with the trisomating. So meconium ileus, cystic fibrosis, Hirschsprung disease, Downs, bicuspid aortic valve is Turner, and diaphragmatic hernias are trisomy 18 Edward. Duodenal atresia is commonly associated with trisomy 21. Holoprosencephaly is associated with Patau. The Ray's syndrome, pediatric aspirin use during influenza or varicella infection. Clinical feature is acute liver fever, acute liver failure, encephalopathy, cerebral edema, increased ICP. Left finding is TLT would be high, PT would be high, PTINR would be high, PTT would be high, and ammonia would be high. There may be microvascular steatosis on liver biopsy. Very high yield microvascular steatosis in the liver biopsy in the context of acute hepatic encephalopathy is consistent with Ray's syndrome. Supportive. Patients should be reminded that aspirin is generally contraindicated in children, but in Kawasaki disease and other JIA, you can give aspirin. Alpha-1 antitrypsin deficiency is characterized by chronic liver function in infants and childhood, followed by emphysema later in the life. Cirrhosis and periportal eosinophilic inclusion bodies typically seen on liver biopsy. Very high yield topic. Interception. Interception. Recent viral infection or rotavirus vaccination. Recent viral infection and rotavirus vaccination. If some baby engaged in rotavirus, they may got these type of interception. Pathological lead point congenital malformation of the intestine. HSP, congenital malformation of the intestine, HSP, celiac disease, intestinal tumor, and polyp. Sudden intermittent abdominal pain, current jelly stool, sausage mass, current jelly stool, sausage mass, and lethargy or altered mental status. There may be target sign. This is target sign. Two concentric circles on ultrasound, extreme soft tissue mass in the right upper quadrant, extreme soft tissue mass in the right upper quadrant, and the Kisantic sign. AR or saline enema surgery if enema reduction is ineffective. This is the ultrasonogram finding. This is ileum, this is colon valve. This is the target sign in interception. Um, in upper quadrant, you may get this type of. In X-ray, you may show soft tissue mass in the right upper quadrant or crescent sign. That is the crescent sign in the right upper quadrant. This is the crescent sign in the right upper quadrant. This is ileum, this is colon wall, and this is colon lumen. Intestinal emergency most common in children 6 to 36 months, not in newborn. 6 to 36 months. Most children have no identifiable lead point, pathologic lead point, recurrent interception, atypical age for interception, atypical location for interception, persistent rectal bleeding during reduction and intermittent contraction of the telescope bowel during peristalsis results in classic presentation of the episodic consolable crying with legs flexed, drawn into abdomen, followed by asymptomatic legs flexed, drawn into abdomen, followed by asymptomatic abdominal X-rays performed to exclude intestinal perforation that would warrant surgical management. Intestinal edema and bleeding can be given in Hirschsprung disease. Bleeding can be associated with inoxion. Purpura can act as a lead point in the intestine to telescope into the adjacent bowel. In most patients with idiopathic intersusception, which is ileocolic, typically ileocolic, intersusception in HSP is usually confined to the small ileoileal, may be treated with contrast enema. They do not reduce ileoileal intersusception that do not reduce spontaneously may often require surgical management. And that's all about. This is target sign. This is present sign. That's all. Hope you enjoyed.